Hi, good evening, everyone, and welcome to this important discussion on endometriosis and the challenges related to it. My name is Amer Raza. I'm a consultant gynecologist and surgeon for endometriosis. Most of my work is around endometriosis. I lead one of the largest national endometriosis centers where we provide cutting-edge treatment and support for patients facing this challenging condition. As a robotic surgeon and advanced laparoscopic specialist, I'm deeply committed to precision surgery that offers better outcome and fastest recovery for the patient. But beyond surgery, I'm also a passionate researcher, constantly working to innovate and improve how we diagnose and treat endometriosis. But tonight is not just about medicine and research, it's about the real stories, struggles, and solutions that matter to patients and to all of us. I am today honored to be joined by remarkable guests who bring unique perspective to this conversation. Together, let's break the silence about endometriosis and push for the change which so many deserve. I am honored here first to introduce Gabriella Pearson, who is making a real difference in the lives of those with endometriosis. Gabz is not only the CEO of Menstrual Health Project, but also a tireless advocate for patients struggling with both the physical and emotional impact of the disease. Her charity's groundbreaking mental health project, Another Help, is providing much needed support to those navigating the challenges of endometriosis, because we all know this condition affects for just more than a body. Gabz is also a passionate, relentless, and deeply committed to ensuring that no one faces this journey alone. She has herself gone through a struggle, and that changed her to help and use her challenges into an opportunity and strength for everyone. Gabz, do you want to say something?
Yeah, thank you so much. That was an amazing introduction, Amer, as always. So, hi everyone. I am Gabz. So, as Amer mentioned, I'm the co-founder of Menstrual Health Project, but I also bring my lived patient perspective discussing endometriosis tonight, which I think is really, really important. I think patient voices are really, really powerful, blending those with medical professionals as well. So I have lots of expert experience by lived experience, which I mean, a lot of us wish we didn't have endometriosis, but it's given me a wealth of knowledge accessing NHS and also private care as well. So lots of experience that, but also my hat as co-founder of Menstrual Health Project. I have a lot of experience now professionally as well to help people with endometriosis and other conditions as well.
Thank you very much, Gabz, and obviously looking forward to hear from you, and obviously lots of questions as well. I'm also very privileged to introduce Dr. Juwairia Hashmi, a highly respected senior general practitioner and former clinical director in Southeast London. She's not only a dedicated healthcare professional, but also a passionate advocate for endometriosis awareness and better care, along with herself suffered with this disease of endometriosis. What makes her perspective even more powerful isn't that just she's treating patients with endometriosis or seeing them in primary care. She has lived through the struggle herself. As someone who has personally battled severe endometriosis, Dr. Hashmi brings a unique and deeply personal insight into the challenges of endometriosis, its diagnosis, treatment, emotional turmoil which goes around with her. So, Juwairia, you want to say something yourself?
Thank you, Mr. Ras. That was a beautiful introduction. Good evening, everyone, and thank you so much for joining us for tonight. I'm Juwairia Hashmi, one of the GPs, and I have been in various roles in primary care, from being clinical director to the chair of the Council of the Members, and I have been a GP tutor for King's Medical School past roles. I am an endometriosis sufferer myself, and I am excited to share my story with you, which will be the first time for me. Thank you very much.
Thank you very much, Juwairia. And before we begin this journey for next 45, 50 minutes with all of you, I want to also take a moment to express my sincere gratitude to Cromwell Hospital. As one of the leading hospitals in London, Cromwell has been at the forefront of providing exceptional care for patients with endometriosis. Their commitment to advancing treatment, raising awareness, and supporting innovation is absolutely second to none. And the work we are doing and doing together is truly invaluable. This webinar would not have been possible without their support. So thank you very much, Cromwell Hospital, and all their team who has supported Hattie, David, and all the team along with it as well. Thank you very much. Now, I think the way I will do it, actually, the format we're going to have for the next few minutes is I'm going to speak some basic things about endometriosis and some innovations. That will lead us to talk to Gabz, actually, about the challenges what we face as a patient when we go into primary care, and then we talk about them. And then Juwairia will bring that perspective that how when somebody goes into primary practice, what challenges they have and how we can make that journey. As the name shows, pain to power. We will start with our pain and challenges, but we will finish it on a hope and a message of strength, that how we can use all this knowledge to make it easier for us to have these opportunities and treat this one. I can see a lot of questions are coming in, so we'll come back to all these questions as well toward the end, and the questions we could not answer, we'll be emailing back those answers to you later on as well. So let me share my screen first. It's a big presentation, but I'll be very briefly just simply flying through it actually in a way as well from this discussion. So I will bring my slides up now, and all of you who are joining us possibly already know about endometriosis, but my few slides over the next 5 to 7 minutes will take you a bird's view, just a quick review of endometriosis and where we are with it as well. As the diagnosis says, the tissue resembling the lining of the womb growing outside the womb, attaching itself to the other pelvic and abdominal organs, causing inflammation, scarring, and cyst, and thus giving the pain. This is one of the most common disease which many have not heard before. 1 in 10 women, more women than people suffer with diabetes in UK, have endometriosis and still is being pushed down as bad periods, which I'm sure many of you have suffered with it as well. It is such a challenge, an enigma, where 10% of women suffer, but we still have no diagnostic test. There is no cure for it. The problem starts right from a very young age in school, all the way from fertility to menopause. It's a multi-organ disease. It doesn't involve just one thing like liver or uterus. No, it goes from one structure to almost every structure in the body it can involve. And it can lead from a normal life to very depression and anxiety. So real challenge in this thing as well. We have, all of you know, and most of you know, that there's a delayed diagnosis of 7 to 9 years, going from GPs to consultants, from clinics to hospitals. It takes a longer time to diagnose. Fertility is the biggest concern, still not being answered. It's such a fundamental thing which everyone needs to have. There's no support as such for infertility when it comes to severe endometriosis. There's a lack of research, lack of awareness. Things obviously are getting better, especially in the last 2 to 3 years with all the support from charities, but we're still long way away from it. And if we want to put it in a couple of words, I can say from a medical perspective that we are in the world of etiological confusion and therapeutic anarchy. We do not know why it's causing it and what's the treatment. I'll come back to hope later on, but that's a fact. When we look at endometriosis, I don't want to take you through all these slides, but the basic message this slide shows that the endometrium lining, which is inside the uterus, is spilling outside or developing outside and causing growth and lesion. It creates its own blood supply, and these small lesions outside the uterus start to grow and involve multiple structures: ovaries, fallopian tubes, rectum, bladder, even going as far as diaphragm, lungs as well. Quite a very serious implications. I will just fly through them. Estrogen is one of the most common thing what actually leads to growth of this tissue, leading to from genetic mutation to even creating its own blood supply, as said as well. I will just go a little bit forward. I don't want to go through the whole pathology, but it shows all those chemical things which goes on. And there's a strong genetic link as well. There's sometimes genetic expression that why endometriosis will grow in many people. And along with that comes the immune dysregulation. So when we come from immunity to all the way to genetics, all these things are playing their role in this disease. And it's not only one symptom. Symptom can vary right from a simple pelvic pain, period pains, to bladder symptoms, bowel symptoms, diarrhea, constipation, abnormal heavy bleeding, going to infertility, and all the way to fatigue, depression, anxiety. It's a long thing. And when we look at the causes, it's not simply one cause, or when doctor sees you, it could be gastrointestinal, gynecological, psychological, urological. So when a doctor sits in the clinic, they really have to look at all the causes of these things to find out where the problem is coming from. And that's possibly one of the problems in primary care as well, that everyone will have some kind of bowel problem, urological issues, a period problem. Picking up that one who has the endometriosis is a challenge among the crowd of symptoms we get, and that's obviously the challenge. The new approach towards endometriosis is absolutely multidisciplinary. Not one consultant or one doctor can diagnose it all and can treat it all. It is the combination of gynecologist, colorectal surgeon, urology, radiology. It's a big team of all this expertise who have to come together to treat. And that's where the British Society of Gynecological Endoscopy accredited endometriosis centers come in. So if you are going for a treatment, it is the accredited center where you want to go and get the treatment. When it comes to, I will just general view coming out of the slides now. When it comes to the new innovation, one of the few innovation now, it comes to the medical diagnosis. Ultrasound scan is now becoming the fundamental tool in an outpatient setting to diagnose endometriosis, along with your history and examination. There has been a huge improvement. Not that everybody who is scanning can diagnose endometriosis. When you see someone who has been trained to do scanning, ultrasound scan, transvaginal scan for endometriosis, can diagnose you in their appointment with the history, examination, and ultrasound scan. And when there is a new disease seen in new tests like endosaliva test, they say at a very early stage, but in which we do not see a visible disease on ultrasound scan, there will be a place possibly for endosaliva, a DNA test as well. So as I said, it is still at an early stage as well. And when the diagnosis is made, the treatment is fundamentally changing now, where there are many medical options now, new medical treatments that are available with the medication. The surgical approach is getting better. I'm sure many of you who have possibly gone through endometriosis know that excisional approach or removing the endometriosis, excising the disease, is a better surgical approach. But this discussion is much more longer about fertility, about ovarian preservation and everything. But surgical approach, minimal access, resecting the disease is the right approach. So this is just a brief view of the whole endometriosis, the way we care, but obviously we'll come back to many, many themes going forward. So I think I will stop it here now, and I will ask Gabriella to come in and give us her own perspective from charity perspective and your own perspective, that how endometriosis is presenting a challenge for all of us. Thank you.
Oh, that's a very good question. Thank you, Amer, because that was very interesting. I've been diagnosed now for 9 years next week, and I still feel, although I'm a lot later on my endometriosis journey, I still feel like I'm learning and trying to navigate, because I think that's one thing I think a lot of people aren't aware is the ongoing challenges when you live with endometriosis, especially if it reoccurs and spreads. For myself, my kind of endometriosis journey started when I started my periods at 10. They were really painful, really heavy, and I missed a lot of primary school. I pretty much stopped doing PE altogether, so I didn't do any sports at school. By 12, my mum took me to the GP and I was put on the pill straight away without kind of any investigation or concern into why somebody so young was struggling with their menstrual health. And back then, none of my friends had started their periods either, so I felt like a bit of an outsider. My mum had always had her menstrual health was fine. My sister, who's 2 years older, she'd started and hers were fine. So I think my mum was quite confused by it as well, because this was back in the late 90s, early 2000s. So and when I speak to a lot of people now, that's kind of their story also, that they had really heavy, painful periods straight on the pill, and then that was just, they were left to their own devices. And then for me, I struggled all the way through high school with it. My symptoms increased. I tried so many different contraceptive pills as a teenager. I felt like a bit of a guinea pig by the end of it. I didn't know anything about kind of what was in the pills, what was right for me, how to track my symptoms and my cycles. So again, I just felt very isolated and alone, because my mum didn't have the knowledge, my doctor didn't have the knowledge, and nobody at school either knew to signpost or what the right information was. So it really impacted me through kind of crucial years of my life. And when I was in year 11, so my last year of high school, I got really bad depression and I ended up leaving and taking my exams from home. And when I'm kind of looking back now at different parts of my life, I didn't realize the big link between my menstrual and my mental health when I was a teenager, and the impact it had on me at a school age, trying to kind of then progress into the next stage of my life. I wanted to go to college and university, and I didn't get to do that because my mental health and my menstrual health were really bad. But then I found when I left school, my gynecological symptoms got a lot worse. So it was pain during and after sex. I was bleeding all of the time outside of having my period. Severe bloating, nausea, fatigue, rectal bleeding. I had really erratic bowel movements as well. So I spent about 6 or 7 years back and forth to the doctors being told it was gluten intolerances, it was IBS, it was stress, it was part of being a woman. I had so many things thrown at me. And although I'm confident now to advocate for myself, I wasn't then. This was when I was 17, 18, being told these things. And I was just like, oh, okay, that's what a doctor's told me, then that must be right. And I won't challenge it, and I won't kind of contest it. I won't do my own research because what the doctor has said is correct, and I have to go with that. And then it just continued to essentially ruin my life. I wasn't able to hold down a job. I just met my husband, so I was really struggling with kind of the intimacy side because my bowel was horrific. I remember having piles at 18 or 19 and all of these things that I think you associate for a lot later in life. And I think that's a big stigma that comes with conditions like endometriosis, that periods, menstrual health, kind of all of these topics have a big taboo. But if you attach anything to do with your bowel or your bladder or anything to do incontinence wise, then there's just a whole nother layer of stigma. And I remember going for my first transvaginal ultrasound because I finally got the doctors to refer me for one, and I'd never had anything invasive done before, and I just cried the whole way through. It was so painful. And I remember going back to the doctors for the results, and she said, oh, it's inconclusive, you'll have to go for another one. And I was like, I don't think I can go for another one. It was so incredibly painful. And she told me that if I really cared about my health, then I would go for another one. So it's unfortunate that myself and other people have suffered the gaslighting and the dismissal in certain situations. And I just remember walking out of there sobbing, thinking, I can't even get the doctor to listen to me, my general practitioner. How am I ever going to figure out what's going on with my body? And I suffered even further then for about 6 to 8 months, back and forth in A&E, just not being taken seriously by the hospital either. And then my mum saw a tiny article in a newspaper about endometriosis, and this was back in 2015. And she said, let's just go and see another GP. We'll just speak to somebody else and see what they say. And my GP was lovely, and she's still my GP today. And I am so grateful for her because we've been on a journey together. And I think it gives people hope that there's some amazing primary care specialists, all different types of medical professionals for people. But she said, oh, let me just have a look at your ultrasound results and see if I can just figure out what's going on. And she said, oh, there are traces of endometriosis on your scan. And I was like, oh, okay, that makes a lot of sense now. So she then referred me to gynecology. And also back then, I didn't know the difference, that there was general gynecologists, there were specialists, there were endometriosis centres. I didn't have any of this knowledge then. I didn't know anything about the guidelines. I had very little knowledge. So when I did get referred to gynecology, I was really lucky to be referred to a specialist straight away, who's still my consultant today. So although I had a weird start to getting diagnosed with endometriosis, I've had really good continuity now with my GP and my endometriosis consultant. But he just said to me that the gold standard for us to diagnose and to figure out how widespread the endometriosis is to do a laparoscopy. And I didn't blink. I was just like, yep, let's do this. I need to know. I thought I was going insane. And I think so many people feel that feeling where they know something is wrong with their body, but they just don't know what it is that's causing all of these issues. And I think for me then as well, I was so worried about my fertility. I was so worried why my organs were having an absolute horrific time and causing me so much pain. So when I was diagnosed, I was just so relieved. I don't think it even entered my head what my life would look like thereafter. I didn't think about anything else, just pure relief that I wasn't going crazy. But I didn't think back then kind of how my life would look. I didn't kind of think at all that there could be any regrowth, that it could spread at all. And when I got diagnosed, it was on my bowel and my left ovary. And I thought, great, he's got rid of it all. Slightly naive, I'll be fine now. And I started a new job, and then I got really poorly again. I was back and forth again in the hospital. And I had a second surgery a year later where I was also diagnosed with adenomyosis. I'd never heard of it, didn't know how to spell it, had no clue what it was. And why I now had this as well as endometriosis. And I remember after being diagnosed with adenomyosis, ever since I've had medical professionals tell me just to get pregnant or just have a hysterectomy, which I think is really, really insensitive, either end of the scale. I was only 24 at the time, so I felt this weird pressure that do I need to just do one or the other? Because again, I didn't have a lot of the medical knowledge. So I think that's a big factor with it as well, is when people aren't given all of the knowledge, whether it's good, bad or ugly, with conditions like endometriosis, but also adenomyosis. But my personal journey, kind of fast forward to now, is I've had 5 total surgeries in total. I've had 3 via the NHS, but I've also had to have 2 privately just because of the waiting times. And unfortunately, my endometriosis has continued to grow back on my bowel and my ovary, but also spread to my bladder and my womb and fuse my organs together. And the damage now for me goes kind of beyond anything that I would expect. And when I say to people that it impacts your fertility, your mobility, your organ function, all of these different things, now I have PMDD, I suffer with fibromyalgia. So it's all of these extra layers of being chronically ill that you have to contend with as an individual. But I think that's a big reason why me and Anna wanted to start the Menstrual Health Project together, is because we've both had really difficult journeys in different ways with trying to be listened to, trying to get diagnosed, trying to access information, trying to access care. Because one thing that we both realise is the disparities, not just across England and Wales, but even just within England, across different care boards and across different areas. Like for me, I have to go to like 5 or 6 different hospitals for different treatment and support as a direct result of my endometriosis. So I think that's what's really tough as well, is that being chronically ill and suffering of endometriosis is like a full-time job. So for me and Anna, when we set up Menstrual Health Project, we wanted people to have all the access to information in one place, and that it's really comprehensive, it's user-friendly, that you know exactly where you are with the condition, and whether it sometimes feels a bit scary to know that information. And I know it sounds cliche, but knowledge really is power. And I'm very much someone, I want to know, even if it's worst case scenarios, even if it is something that is a bit scary, like I want to know my options. And I think, like we've spoken a lot, Amer, about kind of informed decision making and knowing kind of what you're entitled to and what you're up against with this condition. And I think a lot of people aren't given the lay of the land with it. So when we created our endometriosis diagnostic toolkit, which was the first toolkit, we just wanted it to be as user-friendly as possible, that if you think you've got endometriosis, you can look at the symptoms, you can look the best way to speak to a doctor, because that's a really big challenge, is knowing sometimes the language and the best ways to approach medical professionals. And I think from running a charity, I have an appreciation even more so for the medical professionals like yourselves, really trying to work with patients to get them the outcomes, to get the diagnosis, to get the treatment plans. Because I think there are cases where people go in, they leave frustrated, and then they feel stuck. And then there's this narrative that all medical professionals are going to treat you like this and you're never going to get anywhere. And it's unfortunate that people are being treated like this, but me and Anna are big advocates that there are so many amazing medical professionals. So a big part of the charity when we set it up is bridging that gap for people, for patient and professionals, but just having all of that information in one place. Because like when I was being diagnosed, I didn't know anything. I had no knowledge whatsoever. And we always say we're experts by lived experience, and it's a weird kind of catch-22, because you don't want to have the condition, you don't want to have to go through what you've gone through. But I'm also a firm believer in, I want to transform something really traumatic and horrible into something really powerful and good. So I think that's really how Menstrual Health Project was born for me and Anna. But I know there's big challenges for people in school, workplaces. I think in all settings, endometriosis can impact people. But and Amer knows more than anyone as well, being on our board, how much education for us is crucial from a young age, because endometriosis doesn't have a cure. In some people, it's inevitable, but it's about that early diagnosis, being able to make decisions for your own health earlier and feeling as confident as possible to do so.
Thanks very much, Gabz. Thank you. Very, very detailed information you've given us, and very helpful as well. I'm sure many of us on this webinar can relate themselves as well with all the very difficult journey you've taken through. Thanks for sharing it. I'm going to come back to you with many questions I can see.
No worries.
Now, Juwairia, you bring a very unique experience to us as well. Whenever any one of us has any problem, the first door we go and knock is our GPs. GPs are the policemen, the guards of our tertiary services, the main hospital. That's the first place we come to. Tell us yourself, your own experience, and how it reflects on to endometriosis struggles.
Thank you, Amer. Absolutely. I think I am in that perhaps privileged position where I can look from a patient's perspective, and also can talk about the dilemmas that we face as general practitioners. I am going to share my slides and initially start to share my own story. And then I'll come to the dilemma of the primary care, if that's okay. Bear with me. So my struggle, when I go back into the trail of my memories to see where it all might have started for me, I probably would say that it was my mid or late 30s when there were these subtle changes that were happening to me. For example, I can recall going to the supermarket and buying pads for heavier bleeding. I started to put pills, painkillers in my bag so that if I am on my periods, I can just go, just take the pill and continue with my work. I started to have this lower back pain and on and off bloating. But I am a hypothyroid, in my past medical history, this is one of the things. And initially, I blamed all my symptoms on hypothyroidism. But slowly and gradually, these symptoms started to grow over me. And there was a point when, while being on my periods, I was enjoying that weekend with my family, and I fainted because of severe pain. And it was from that point onwards that I went back and forth to the GP and to the NHS hospital. I had 2 transvaginal scans, and on both of the scans, I was told that it is just a bulky uterus, which we call as adenomyosis, and there's nothing else to worry about. But in the bottom of my heart, I knew there was something not right. I wasn't feeling sufficient for the job that I was doing. So I went to a local private gynecologist who arranged a MRI with contrast for me. And when I still remember my follow-up appointment with him, and he also said that it's probably your bulky uterus, and probably there is a small defect in your cesarean scar. I conceived both of my children naturally. So for me to go to this journey of endometriosis is a little bit atypical. And probably he said that we can offer you treatment to repair that scar, which I refused. And he said there might be a bit of an element of endometriosis. So I remember the outcome of that appointment was that I left his office by taking my symptoms back with me, and feeling like a drama, that it is just a bulky uterus, and I've had this faint and I can't cope with this every month. um, Above all, I became dismissive because I thought I've had two scans, I've had an MRI, probably it is just the bulky uterus and I'm not able to cope with it. So I became dismissive of my pain. I became dismissive of the every monthly struggle that I was having, thinking it is the adenomyosis because I've been now checked. And I persevered with this for 1.5 years up until the pain then again urged me to come and seek help. And that was that point when I came to you. And we had the investigations done, and it showed that I had a 6.5 centimeter cyst on my left ovary and 3.5 centimeter cysts on my right ovary. And I had stage 4 endometriosis, and all the organs in my pelvis were covered with the endometriosis. And at that point, I remember, the decision that I took was that I'll go with the hysterectomy, with the removal of my ovaries, and it was a 6.5 hours procedure, and it was nearly 8.5 months ago from today, Mr. Raza. And what I remember is that a month ago, I decided to find a purpose of this journey of mine, and today is my first step towards it. So when I come to now I'll speak from the dilemma of the GP. The first and foremost thing is that GPs are less in number and they cover and care for a bigger population than they should be. Hence, there are less appointments, there are less timely follow-ups. And when you go and see your GP, they are strictly under the constraints of the time. That's the big elephant in the room. Absolutely and imminently, there is a need for GP awareness, GP education, and training that not only enables them to identify this condition before time for earlier diagnosis, but also gives them the confidence to treat the patients initially while they're waiting for their appointment with the specialists. We really need to review our current protocols and systems in the primary care. And if I have to make a wish list, the top will be to have a tracker or an app that we can perhaps amalgamate into our clinical systems currently that we have in our GPs, so that the GP can have an overview of the monthly or the yearly cycle of either the women. And that perhaps is a very proactive approach towards the women's health. And I wish there will be a time that happens. We all are aware of the NHS barriers and waiting time. And it is an underfunded area in primary care. And there is a huge lack of not only endometriosis, but also menstrual health services, because in my opinion, we require trained nurses, trained GPs, trained sonographers, trained dietitians, and physiotherapists for it. Now, I would also like to, bring this to audience that when you are going to your GP, how can you use your GPs most effectively in those 10 minutes? So first of all, keep your smears, swabs, and bloods up to date. Remember, no symptom is a little symptom. And track your cycle. Write down. Whether you use a notebook, a journal, or use a tracker, or you use an app, track your symptoms, put down your periods in a form of writing, and look back and take those findings with you to your GP so that it is less difficult for you to express what you're going through, and it's easier for the GP to understand what's happening to you. And if you're still not satisfied, think of a second opinion, go for a second opinion. Please give feedback, because system will only improve with your feedback. So this is my take on it, Amer, and this comes from a patient's perspective and also from a GP's perspective. And I hope I've been of any benefit or use to the audience tonight.
Thank you very much, Juwairia. Very helpful, very practical tips as well, which we all need when we go to a GP. I think I will just say a few things and then we'll come to question answer session as well, which I'm sure I can see a huge amount of questions are coming in now. Number one, yes, it's a challenge, but I can also say from medical perspective, there's a hope as well. There's a lot more research going on in endometriosis than ever before. Right, not only in UK from Oxford to Edinburgh and many centers in the world where lots of work is going on in endometriosis, looking at the genetic coding of endometriosis, looking at the specific markers which can be blocked and can be treated, looking at the immunotherapy solutions, very innovative solutions. They may not be in the market for next year, the year after, but huge amount of work is going on, right? Starting from the diagnosis, how we can diagnose with the DNA test, with the genetic test, all the way to different treatment options, and obviously better surgical approach. Surgical approach is in itself is not a cure of your problem. It is just a solution of the disease, what has grown over many years, but the solution will come with some kind of medical treatment. And secondly, medical treatment alone is not the solution in itself as well. Diet, changing your dietary habits, all the new research which is coming in, it's coming out from our food, what we eat, what we are putting in, that changes the genetic biome of our body. And that translates into inflammatory markers, which makes the endometriosis pain worse. That's where the research is going in, and hopefully solutions will come that how can we change our dietary habits, nutrition, and things which consume, that how they can help us. Pelvic floor exercises, psychotherapy, all these things come in to help to cope with this challenging situation. So a huge amount of work is going on, and I think there's a good hope in the coming months and years we'll hear good news. Royal College of Obs and Gynae, British Society of Gynaecological Society are doing a huge amount of work and campaigning to the government to bring gynecology and especially endometriosis on the top of their agenda. It is still not on top of their agenda. The most recent report came in wasn't very positive. So a lot more work needs to be done. Thanks to people like Gabz, Amer, Menstrual Health Project, Endometriosis UK, other societies as well, which are raising their voices and they are making difference. Parliament is listening, but we all of us who are in this forum today as well need to raise our voices wherever we are to make the awareness better. Now, when it comes to questions, I have lots of questions for Gabz and Juwairia as well, but I thought better me asking question. Why not we should take the question what have been posted here and we try to answer those questions. So I will try to take up the medical question, but the secret is going to be we have to really answer quickly. So quick answer. We get the answer, and the answers we cannot give today, we will be then emailing you all those answers as well. So don't worry if you missed out as well. So I think Hattie is with us now. Hattie, are you there? And can you read us the questions? And we will try to answer as many as questions we can do.
Yes, of course. So the first question is, with so many young women being advised to have a full hysterectomy, which we know isn't a cure for endometriosis, the mental turmoil of going through menopause so young is so overwhelming. What resources are available to support women making this decision?
So I will say the medical thing, and then because this option has been given to Gabz as well, she will tell us about the emotional. From my perspective, if you are young, then it's not fair to give you the option of hysterectomy. Hysterectomy usually is given in the context of adenomyosis, when your doctor will say your pain will not get better, do adenomyosis. So my answer will be no. There are a number of things you can do. Number one, medical hormonal suppression. There are many new medications available which can suppress your hormones, can create temporary menopause. I know there'll be a lot of side effects, and many of you will be asking questions that we have bad side effects, so we better not take any hormonal treatment. But that's kind of a discussion you need to have with your consultant, and you can try not 1, 2, 3, and something will come up. So there are very effective medical treatments, new medications in the market now, which can be used for medical suppression, helping your pain. Secondly, more than medication, is dietary modification, is psychiatric help, physical help, pelvic floor exercises. There are many other avenues you can use to help your symptoms as well. So hysterectomy shouldn't be the one, especially for young people, who should be offered as well. And surgical treatment of excision of endometriosis is definitely a viable surgical option as well to help with your symptoms. So that's the medical answer. Gabz, go ahead, please.
So I guess from a patient signposting perspective, so we, in our new toolkit, the Menstrual Health for over 18s, we've done a bigger section on the different types of menopause and have put kind of just very simple but effective information. But I would say if you're going to be having a hysterectomy, I would say do your research, look for accreditable sources to get your menopause information. We have 2 GPs on our trustee board that both specialise in menopause, who are fantastic, and we're planning to do some webinars and sessions on menopause. But there's also a really good menopause charity called Menopause Support, which is run by Diane Danzer-Brink. So she went into surgical menopause because of endometriosis and adenomyosis. So I would go to charities, I would go to information resources and do your homework, because I think menopause is a really complex issue. And again, it's another area. Don't feel afraid to challenge it as a patient. I have learned so much about menopause from being in chemical menopause, but also ana and surgical menopause. So I would say reach out. I'd also speak to your doctor, your gynaecologist, whoever you're under, about the mental health support as well, because that is a huge aspect. And I think you should always be able to ask for that support. And if they're not able to give that to you, ask to be referred to somebody that can give that to you, because the mental toll of it, I can only imagine, is absolutely horrific. So if we can do anything to help anyone who is going through a hysterectomy or has been, please reach out to us and we can signpost you to the right people as well.
Thank you. Next.
If endometrioma is found in a scan, does it always indicate severe endometriosis, and how should it be monitored and treated?
So if there's an endometrioma, it does not automatically mean severe endometriosis. But when endometrioma means endometriosis found in the ovary, there is almost 80% chance that there will be peritoneal endometriosis as well, means around the ovary. The treatment is something you have to discuss very carefully with your doctor, because if endometrioma is found and you're young and you want to conceive, they should do some blood tests to check your AMH, FSH, LH, especially AMH, to check your fertility perspective, and then they should give you advice accordingly. In the past, for endometrioma, we used to strip the cyst, but we've stopped doing it because we understand now by stripping the cyst from the ovary, it causes damage to the ovarian tissues. So now aspiration and various other treatment like alcohol, sclerotherapy, and other treatments your doctors will discuss with you. But if endometrioma is diagnosed, it doesn't automatically mean you have a severe endometriosis, but there's a possibility in 80% that you will have more endometriosis around the ovaries as well. Yep, next.
What alternatives exist for those who cannot tolerate hormonal treatments other than pain relief?
Gabz, you can come in, and Juwairia may add something.
What did you say, Hattie? What options are available?
What alternatives exist for those who cannot tolerate hormonal treatments other than pain relief?
Oh, see, I think it's a real fine line between a holistic approach and a medical approach in terms of kind of medical treatment. So for me, I know people are going to be like, really? Heat is one of the best things for me. If I'm struggling with pain, a bath or an electric heat pad. I do caution people with hot water bottles because they're really dangerous if they burst or if you're just putting boiling hot water in them. So I used to be a hot water bottle girl, and now I'm an electric heat pad person. You can adjust the heat settings, you can put a timer on it. They're really lightweight and effective. So I think heat's a big one. You can get things like natural pain relief patches as well, so they're discreet when you're on the go. But it is trial and error when it comes to natural pain relief things. So I would just say, again, speak to people in the community. Using the online community is a really powerful tool when it's looking at alternative options.
Yeah. I absolutely agree with Gabz there that it's a very personal sort of an approach that one has to have when it comes to pain relief, and if the options are limited, with along with the heat and with the holistic approach, again there is another concept where how to manage the pain and overcome the pain psychologically, and to have those sessions to see if that can help. But that is again applicable for a few individuals, and it is completely not applicable for a few, as pain is a very subjective symptom. So having a psychological therapy, how to overcome your pain, also helps.
Thank you. Ati?
What sort of diet and lifestyle is good for endometriosis?
I'll go back to Gabz and Juwairia.
Oh, see, there's quite a lot of controversy online at the moment about the AIP diet, and I won't lie, it's really split the endometriosis community. And I know there's not a lot of research into specific diets like that working for kind of people as a whole. So I think from a patient, it's really hard to sift through it online as well, because you're being told to go gluten intolerant, dairy free, all of these different things. So as a GP, Joe, is there something that you feel as a GP is like the best approach for people? Because there is a lot of controversy, especially at the minute, for people.
There is indeed. And what I have found useful for the patients and for myself as well is low FODMAP diet. It has really helped me. Again, there's a controversy around that as well as adding on natural anti-inflammatory herbs also helps with symptoms of endometriosis, especially when it comes to turmeric. It has known to be very effective. Yes, it's known to be very effective. So I would say that low FODMAP diet. What is your opinion, Ms. Amer, about that?
I'm very passionate about dietary advice, and I think when I talk about 4 pillars of endometriosis treatment, I tell them first thing is diagnosis and surgery, second is a medical treatment with a hormonal suppression, third is dietary modification, and fourth is pelvic floor exercises, especially more emphasis with Pilates with pelvic floor thing. These 4 are just fundamental, and then obviously psychotherapy and all the support along with it will come as well. So dietary modification, anti-inflammatory diet. Yes, everybody needs to speak to their own dietitian, nutritionist to see how they can modify. But if I have to just create a bigger umbrella, which obviously won't fit to everyone, is to reduce carbohydrates, especially white carbohydrates. They can obviously have a brown, wholemeal or grainy carbohydrates. They should reduce dairy and sugary products. Again, it doesn't apply to everybody. It doesn't mean all dairy, some products. And they need to increase the protein and high fiber and drink plenty of fluids. These things, generally speaking, in most people help, but obviously we can all have individual variation. But diet is a fundamental thing to change, so everybody should put emphasis on it. And there are lots of online resources as well. Thank you. Hattie.
For non-period endometriosis symptoms like bladder pain, pelvic pain, which treatments are most effective? Do hormonal contraceptives help, or is surgery the best option?
Depends on what kind of non-hormonal treatment you have. So if I want to talk about 2 most common one, there'll be either urinary problem because bladder is involved, or bowel is involved with bowel issues, bloating, spasmodic pain while passing stools called as dyschezia, or bleeding per rectum are one of the most common things. Once you have this problem, it's very important to first of all diagnose the extent of the disease and involvement of the extent of the involvement of these organs. Because if these structures are involved heavily, then surgical treatment will be needed, and that's where the multidisciplinary approach comes. Now, as we said before, the first talk, that estrogen is the primary cause for endometriosis growth. So yes, estrogen hormonal suppression will help to relieve the symptoms. But if endometriosis has involved the bladder or the bowel or the ureters, then it can affect the functionality of these organs, which can have a long-term impact on the health. So it's very important that if any of the other systemic organs are involved, have full investigation in a proper center where all specialists are available, and they will do all the respective investigation from MRI scan, colonoscopy, cystoscopy, and then decide where the disease is, and then give you various alternative options, including surgery.
I think that's where it gets difficult sometimes from a patient perspective, where when you have like bowel and bladder issues, like for me, my bowel function is really reduced because of the endometriosis keep growing on my bowel and fusing my organs together. So it's then being referred to lots of different departments. And for me, I think gastro I've struggled the most with to get any movement. It's been very underwhelming, unfortunately, and they've done a few tests and then they've just gone, nope, it's just IBS, you just need to see a dietitian. And it was really frustrating because I know that something's not right with the function of my bowel. And I think sometimes as a patient, it's really difficult when you're trying to present your case and it kind of feels like it's falling on deaf ears in certain situations. And I'm really lucky because I'm under some other really good specialists. So I've now been referred to a different hospital that specializes even further in kind of neuromodulation, looking at pain and bowel together. But I guess I just have a quick question for you, Amer, if it's all right to interject, or for you, Juwairia, as well, is that if someone is at that point where they're kind of stuck when it comes to like bowel or bladder, like what is the best way to navigate that? Like everyone's not lucky like me, where I have other really great specialists who fight in my corner. I have the knowledge where I work with lots of professionals where they're telling me the inside track and the best way and what to ask for and who to go to. But what's kind of, I guess, the most simple way to put it for someone to get that as well if they need it?
Yeah, I think for a patient as an individual, it will be quite a challenging task. And you're right, because you know people you probably speak to. Now, from a patient perspective, multidisciplinary approach is the key, that how much that entity is responsive to your questions. For me, when it comes to bowel issues, first of all, surgically to excise the disease from the bowel, that's one. Two, not everybody will get better after that surgical excision of endometriosis from the bowel. It could be disc, shave, or even bowel resection, because sometimes there will be underlying functional bowel issues as well. That's where the functional gastroenterologist will come in to do their investigation to see how they can improve the functionality of the bowel. And a third person which comes into the discussion is your chronic pain team, looking at the neuromodulation things what Gabz told us. Now, these three components, the surgeon itself, gynecology surgeon, endometriosis surgeon, the colorectal specialist who's removing the disease, the functional gastroenterologist who's looking at the functional element, and a chronic pain specialist from neuromodulation expert, when they sit together on one table with one patient with their problem and ongoing issues, they should come up with a plan of care. So I will say to all patients who are listening and bowel issues, absolutely go back to your consultants, your endometriosis team, and push them to discuss your case in that format of MDT, where these things should be discussed and they should be giving you a good solution for your problems.
Yeah, I'll have to add on here, Gabz. So my symptoms, which urged me at the end to come to Amer, was that I was actually having severe pain when I was passing urine at the start of urination. And I was very perplexed if it is my kidneys, because my uterus and ovaries have been checked and there's nothing wrong at all, as far as I know. So I actually presented with urine symptoms, saying that there's something wrong with my bladder or my urine. And I remember having the MDT meeting and the pros and cons of the procedures that were discussed at that time. So I think it depends how much is the extent of that, the endometriosis, and which part is it affecting.
Yeah, that's right.
I agree.
How do I manage continuity of care? I've been sent privately to different hospitals for different parts of my diagnosis and treatment, and they aren't communicating between themselves or the NHS, which often leaves me to relay information, but they won't accept my word or what's been happening, leaving me repeatedly stuck trying to prove what's happening and chasing documentation.
Juwairia, you sit in the middle of all these things, isn't it? So tell us.
Oh, I'm really sorry to hear that. And I think your GP can play a huge role there. Certainly, because they are the ones who will be receiving the correspondence from every corner. So maybe having a few follow-up or some sort of, now the GP appointments, you can not only, you could see them face to face, you can ask for a telephone appointment, and you could also fill in an online form that can go to the to the practice. And I believe that your GP can play a huge role in that. and should be the main central role in your particular case.
Yeah, that's right. Okay. Ati?
Is there a limit to a number of endometriosis surgeries a person can have? And then a bit of a follow-up. If you have the surgery, fall pregnant, and then it develops again, potentially preventing further pregnancies, is it worth having a second operation?
So this is a difficult question. Having multiple surgeries is a no cure for your ongoing pain, and every surgery will add to the risk of the next operation. Surgeries lead to adhesions and scarring, and that leads to more problems, chronic pain, even neuropathic pain as well, the scarring resulting from the surgery. So every surgical decision, from first surgery to repeat surgery, needs to be very carefully calibrated against the risks for that operation. So this is something obviously you have to discuss with your surgeons to see. Sometimes we have to. Some people will have multiple surgeries because endometriomas have come back, or they had one surgery, but then some other organs like bowel, bladder have malfunction, and now they need to have another surgery for those issues. So sometimes there will be multiple various other problems along with endometriosis of the pelvis, which will need more surgeries. But we should be very reluctant to have surgeries and think very carefully and hard with our clinical teams before making a decision about repeat operations or repeated operations.
Can someone have adenomyosis without endometriosis, or do they occur together? What are the key differences?
It's likely that adenomyosis and endometriosis will happen together. Endometriosis means that endometrial glands have gone inside the pelvis, outside the uterus, and start to grow. But sometimes this endometriosis disease in the pelvis can be very subtle, can be superficial, can be microscopic. So by ultrasound scan, MR scan may not be able to see. Even laparoscopy sometimes can miss this microscopic lesion. But if someone has adenomyosis, it's very likely they will have endometriosis as well.
What's your advice for dealing with a general gynaecologist who's dismissive of these conditions and is not convinced that they're the cause of pain? How do we best converse with them to ensure we get help?
Gabz can tell us. She has all the tricks and given a good suit as well.
Might be a bit controversial. I think the biggest problem, and I'm sure you both agree, is if there's lack of knowledge from a general gynaecologist and there's the lack of humility to say, I don't have the skill or the experience to help you. So I'd say from a patient perspective, ask to be referred to a specialist. If you're met with difficulty doing so, I say this not just go ahead and complain, but don't be afraid to complain. And Amer always says, and we always talk about, you can ask for a second opinion. If you're not getting the care that you're entitled to, you are allowed to make a complaint, and there are ways to do that. You've got PALS, which is patient liaison. If you don't feel like you're getting anywhere with that, I tend to, and this might be a bit controversial, is I will find who the chief exec or who the managing director is for the care board, and I will email them. I will copy them into emails. And I know sometimes that tactic might be a little bit scary, but your health, you get one health. It's really, really important that you exercise your rights as a patient to access the best care. But I would also signpost your gynaecologist to specialists like Amer or to charities like ours, where we've got the information, we've got the toolkit. So it's irrefutable if you have that information and knowledge for them. And if they're not able to help you, then they need to refer you on to a specialist. It's as simple as that.
I will just add something to that as well. And that's a secret thing. Don't tell, please, any doctors about it. When you sit in the clinic with us, and you're telling your history, and then I dismiss you, absolutely do not be afraid to challenge the doctors. They do think. I know some of them can be difficult or stubborn, but most will sit back. They will listen that she's telling me she may have this problem. When you come to a clinic, go to MHP, Endometriosis UK charity, things as questions as well. Go prepared. Go through your questions. Write them down. If you have not written them down, you will go into that 20-minute very stressful situation, you will forget more than half of your question. If you write them down, even if the clock is saying it's 20 minutes and you have 5 questions left, I'm afraid they will have to answer you. So be prepared, go prepared with your answer, absolutely challenge them and tell them this is my symptom. Don't you think it could be endometriosis? Use this word. Don't you think it could be endometriosis? Trust me, they will think second time before they're saying no to you.
Yeah. No symptom is little. And if you are not happy, think of a second opinion and ask for a second opinion.
Yeah. Actually, but almost carry on.
Sorry. How will endometriosis affect menopausal symptoms?
Endometriosis primarily is an estrogen-dependent disease. Technically, when we go into menopause, there is no estrogen, and if there's no estrogen, endometriosis should get better, but that's what happens. Endometriosis leads to fibrosis, adhesions, and scar tissue inside the abdomen. So even if my estrogen has gone down and inflammation has gone down, that scarring and adhesion may affect many organs and the functionality of many organs. So being in menopause doesn't mean endometriosis has gone away or that endometriosis-led adhesion scarring has gone away. That may still have some implications and causing pain as well. So even if there's a menopause, there's a possibility there could be active endometriosis symptom, and some of them will go on to hormone replacement therapy, and that creates another challenge as well, sometimes activating the endometriotic lesion.
What's the best-in-class treatment for rectal endometriosis? I've had 4 laparoscopic surgeries over the past 6 years, but all seem not to be effective.
Gabz, please go.
Oh, see, it's difficult for me because I am a patient where I have bowel endometriosis and I've had 5 surgeries and I don't feel my bowels any better, which is really unfortunate. And I think sometimes people will say to me, but you've had excision with a specialist. They've obviously not done a good job, but the disease doesn't equate to the specialist or the work that they've done. So it's just really complex. And for me, I still get really bad rectal bleeding, piles, erratic bowel. And this is when we're talking about, and Juwairia, you'll understand and support this as well, that it's multidisciplinary. So it's not just the surgery and then that's it. It doesn't always mean that just having the surgery is fixing it. It's just essentially, in a way, it's a small part of a much bigger issue that kind of then stays with you post-surgery. And I think a lot of people can sometimes feel disappointed when they've had a surgery and their relief isn't maybe as much as they think it is. I don't know if you feel the same, Juwairia, when you've had surgery or on your journey as well.
Yes, I agree. So the relief might be partial. You might not find much of the relief and the symptoms can come back. Endometriosis can grow back. So this is the dilemma of this disease, this condition. And absolutely, I agree with you, Gabz. It's a multi-dimensional, multifactorial condition, and it requires, various specialists, the gynecologist, the urologist, the bowel specialists. And, it tends to reoccur. That's another thing, which is quite challenging. So I think Amer would be the best person to answer if there's further more to add. But I think from my perspective as a patient and as a doctor and Gab's perspective as a, expert patient, that's all that can be done.
It's tricky. And I think such sensitive organs like your bowel and your bladder as well, it's really tricky. And I also find as well, then there's so many other kind of factors. There's stress, there's pain, there's sleep, all of these other things as well. And I think I sometimes feel that, and I was talking about people kind of being told the full scope of the condition, and I guess the outcome post-surgery is that I say to people that I'm under pain management, and people are like, what's pain management? How do I get referred to it? So I think it's about medical professionals being forthcoming and using the multidisciplinary approach and saying to people, you've had this surgery now, but there is the risk of this. Let's refer you for this. Let's be proactive, because like it took me until last year, so almost 8 years after being diagnosed, to be referred for pelvic floor physio, and we have one across the whole care board. So you can imagine you barely get to see the person, but things like pelvic floor is so beneficial, because she told me so much in the space of an hour that I have ever been told in 8 years, and so many things I wish I'd known earlier that could have improved things with my bowel function, my bladder. So yeah, I think it is a really disappointing condition in the fact that you don't just go in for a surgery, you have this difficult testing surgery, and then you're on the road to recovery. In a lot of ways, it's not how it works. And I think some people aren't told that by consultants. And I think sometimes it just boils down to lack of knowledge and experience. Sometimes I think they don't want to sometimes have those difficult conversations, because they are difficult.
I believe, Gabz, it's like, you know, perhaps there's a severity of the symptom, and then there is endometriosis. So surgery is perhaps to take away that severity, and then you have to manage the condition.
Yeah.
And this is how it is. But it becomes easier with the support groups, you know, especially like, you know, you're doing an excellent work. And I think support groups like yours, I've just taken a small leap of opening up my own Instagram page in my own little way to help
That's brilliant.
you know, as much as I can. So I think, you know, pages like this, support groups like this will help. And we are a huge majority. 1 in 10 women are having it. So we are a huge majority of women going through this together.
Yeah, I definitely think the statistic is, I personally think like 1 in 6 now, because I don't think I go anywhere where someone's like, I have it, or their sister or their wife or somebody they know. It's insane the amount of people now that have it. And I think it's not a shock in a sense. I think it's just more people are now being diagnosed because they feel more confident to go and advocate for themselves and approach their doctors. I think I know people that have suffered for 10, 20, 30, 40 years, and I just feel like it's just not good enough for all of us to be suffering so much and in silence, especially the knock on it has across your whole life, I was saying. And that's another thing, like when I got diagnosed, I was like, oh, okay, I've had my surgery, I'll be fine now. And I don't think I thought about all the things that it impacts me now. And I think that's really important for me when I'm advocating, is saying to people like, this may not be your situation or your future, but it could be. So it's about knowing the signs and the symptoms and having access to different departments, because there's so many things that I've not been offered I've not been asked to have willingly. I've had to really fight to have it to support me with endometriosis. And I think I'm a big fighter for that. I feel like people need to have more options, because it's not viable, I think, telling young people that to just have a hysterectomy or that they've exhausted all their options. I think we need to think outside the box more in terms of chronic pain as well.
We have, and from where I can see, you know, I have a 15-year-old daughter, and I feel like giving her the information of what is normal, what is not normal for her periods, when should she be worried about, is something that I'm very passionate about, because I believe that once we have got the awareness at it, you know, at this age group, perhaps we will have a more, you know, it will be easier for the future generation to be diagnosed. Perhaps, I hope there's no endometriosis, but, you know, that's a wishful thinking.
Touch wood.
So yes.
Thank you. Thank you very much. Hattie.
Thank you. Would you like a further question? We'll make sure to put them all together and get them answered for everybody.
Yeah, I think I would just say in the end, thank you very much for all of you who have participated here, and so many of you stayed all the way through this journey. It is a discussion which will not finish, which will not end. This is a fight which will not end, but we have to all keep working together. Patients, doctors, nurses, charities, all of us have to work in our own way to help the patients. So let's keep going with this journey. and all the questions you've asked us today. We will come back to you. Our specialist nurse Janai will be sending you all the answers as well. But thank you very much and look forward to see you again. Thank you very much, Dr. Juwairia Hashmi. Thank you very much, Gabz, as well, to come and join us today. It's been extremely insightful and helpful for you to join us and talk about endometriosis. Thank you. And thank you, Cromwell Hospital, as well, once again, for all this support.
Thank you both. Bye-bye.
Thank you.
Patty?